Good evening, dear participants and respected teachers, all of you. আমার কথা শোনা যাচ্ছে clear?
Clear.
Okay. Good evening, everyone. Welcome to today's webinar, ABC of joint replacement. So we arrange a comprehensive course on the management of arthroplasty, especially for the total hip and total knee arthroplasty. We started this session from last week. On the last week, there was talk about the patient selection and preoperative X-ray evaluation for the total hip replacement. And for total hip replacement, our objective is to make a painless, stable, mobile, and durable joint. This will be our objective or motto for total hip replacement. To obtain this thing, so we have to choose a proper implant for our selected patient, as well as we have to take proper decision whether we'll go for cementing or not. Okay, that's why today's talk is about choosing an implant for total hip replacement and cementing technique. So our mission is that it is to give proper education to the orthopedic surgeons who are interested in the joint replacement surgery, thus to improve the skill of surgery and reduce the complication related to the joint replacement procedure. So our today's panel of experts are our country's very eminent orthopedic surgeon. We are very much proud to have such panel of experts for today's webinar. I welcome all of our panel of experts. First of all, I welcome Professor Abdul Rizvi sir, who is the ex-director of NITOR and ex-president of Bangladesh Orthopedic Society. And now he is working as senior consultant and director in Green Life Medical College and Hospital. And he is also now president of Bangladesh Spine Society. Sir, I welcome you to today's webinar and thanks you for giving your precious time to us. Next of all, I am welcoming Professor Zaffar Chowdhury sir. He is the chairman of Department of Orthopedics, Bangabandhu Sheikh Mujib Medical University. I am also welcoming you sir for today's seminar. And our last panel of expert is Dr. Amir Hossain, who is the associate professor and head of the department in Shohid Sohrawardi Medical College and Hospital. I welcome all of the panel of experts today's for their gracious presence. And today's two most important speakers are, first of all, Professor Dr. Hasan Masud sir. He is the professor and head of the department, Sir Solibullah Medical College and Midford Hospital, who will talk about choosing an implant of total hip replacement. And the second topic is for cementing technique. It will be taught by Dr. Jahangir Tuhin. He is the assistant professor in Chittagong Medical College and Hospital. Now may I request Dr. first of all, Professor Dr. Hasan Masud sir to start his presentation by sharing his link. Professor Dr. Hasan Masud.
Thank you, Dr. Shantanu. I'm sharing my screen. Am I audible?
Yes, you are audible. Yes, you are audible, sir. Okay. Just an announcement for all the participants. Please mute all of your microphone during the presentation and give your question. If there is any query, please put in on the chat box. We have a very attractive question and answer session after end of each presentation. Thank you.
So, Assalamu alaikum and a very good evening to everyone. Today, I will be talking on choosing an implant for total hip replacement. You know very well Dr. Ranawat. And now, from the lecture, we would be able to learn about the principles of various femoral and acetabular components used in total hip replacement. And we also recapitulate of basic components of THR and differentiate the use of cemented and uncemented components and some knowledge to apply in handling complicated cases. And for total hip components, the two components, one is femoral component, in another is acetabular component. So total hip femoral and acetabular components of various materials and a multitude of designs are currently available. Few implant designs prove to be clearly superior or inferior to others. Certain design features of a given implant may provide an advantage in selected situations. Properly selected and implanted total hip components of most designs can be expected to yield satisfactory results in a high percentage of patients. And you know, arthroplasty is the operation of century now. So no implant design or system is appropriate for every patient. And a general knowledge of the variety of component designs and their strengths and weakness is an asset to the surgeon. And selection is based on the patient's needs, the patient's anticipated longevity and the level of activity, the bone quality and dimensions, the ready availability of implants and proper instrumentation, and the experience of the surgeon. So I will be talking first about the femoral component. See in the left side, this is the Charnley total hip femoral component. This is a monoblock component, but now the femoral component is available in modular head, modular neck, and modular stem also. Sometimes the neck and stem is combined together. So goal of a sound, stable hip joint is restoration of normal center of rotation of head by maintaining 3 offsets. What are the offsets? One is you know very well, this is the medial offset or horizontal offset. This is the vertical offset, and there is another offset which is called anterior offset. It is nothing but the version, the entry version of the femoral head and neck. So see here, this is the modular head. Modular head means there are different size of head which fit for the patient. But see, this is the neutral head, this is the plus head, and these are the minus head. So if you use the large head, it will increase both the medial or horizontal offset and also the vertical offset. But if the vertical offset is increased, there may be chance of lengthening of the hip, lengthening of the femur, and as a whole the lengthening of the limb. So without limb lengthening, is there any possibility? Yes, when you decrease the neck shaft angle and use the large head, it will cause the increase in the medial offset, but it will not increase the vertical offset. So no chance of lengthening. This type of implants are also available in the market, though not this time in Bangladesh, but all over the world they are available. So here, see, this is a large head and it is non-skirted head, and it is this head has a skirt, like a skirt. So in case of a small head, skirted head, it has less range of motion, and so more chance of impingement. And this is the large head with no skirt, that means non-skirted head. It has large range of motion and decreased chance of impingement. And see here, this is the large head and this is the small head. And you see in large head there is more arc of motion and less chance of impingement. And another thing, in large head, this jump distance is more, and in a small head the jump distance is less. So as here the jump distance is more, so less chance of dislocation. So there are many sizes available now, and initially it was the 22 in Charnley's head, and now there is 26, 28, 32. But we prefer to use head size more like 32 or more than 32. But it is individualized for the patients. And what are the advantages of large head size? There is increased range of motion, decreased chance of impingement, less chances of dislocation, and less wear and more stability. And a small head size had some disadvantage, but sometimes a small head size is needed for the patient, and I will say about that. And now there is the modular neck prosthesis. Sometimes the neck is attached to the stem, but sometimes it is modular. So modularity make possible to adjust the offset and also the length. So here, trial reduction with head allows assessment of length, offset, and version. That means 3 offsets should be maintained. And now come about the femoral fixation. There are cemented fixation and non-cemented fixation. What percent of patients cemented versus uncemented are in your practice presently? And what is the trend? It is called North Atlantic divide. This is the North Atlantic Ocean, and one side there is North America and another side there is Europe. So in Europe, which is the birthplace of John Charlie, they follow their boss and they mostly do the cemented prosthesis. And in North America, they are more uncemented prosthesis. So in 1960, late John Charlie has done pioneer work in all aspects of total hip replacement, including the concept of low frictional torque arthroplasty, surgical alteration of the hip biomechanics, lubrication materials, design, and clear air operating room environment. And he also studied about the bone cement use in case of total hip replacement. And for the implant selection of the femur, there are many criteria like the age, the activity, what is the diagnosis, and what is the canal geometry. And about the canal geometry, I'll talk later on. And now, first the cemented theater. It started in 1960s. Today, long-term results are available. Problem is with polywear and poor cement mantle, but it is a good indication for cemented hip. So cemented stem, see, this is the collar stem with collar, and this is the collarless stem. Their surface finish are different, like polished stem, matte stem, or grid blasted stem. So the stem should be fabricated of high strength alloy. Most designers favor cobalt chrome alloy because its higher modulus of elasticity may reduce stresses within the proximal cement mantle. The cross section of the stem should have a broad medial border and preferably broader lateral border to load the proximal cement mantle in compression. And a collar aids in determining the depth of insertion and may diminish resorption of bone in the medial neck. And see different types of stem, cemented stem. This is called CPT stem, collarless, polished, tapered stem. In abbreviation, CPT stem. And another stem, this is summit stem with collar, and this is omnifit stem, which is also with collar. So cemented hips are cheaper than uncemented hips. Many patients are poor in our country, so you have to bear in mind about the cemented hip in most of the cases, if it is needed or if it is appropriate. And another thing, please, when you are doing the uncemented hip, please keep ready cemented hip because sometimes it is needed. And revising a cemented hip is much easier than revising a well-ingrown uncemented hip. So this is the proximal femoral canal geometry, and there is a classification called dot classification. It is dot type of A, where the medial, lateral wall, and posterior wall is thick, and this is a champagne flute appearance of the canal. In these cases, uncemented hip is appropriate, and this is also dot stripe B. In this case, the medial and posterior wall is thin or there is loss of bone, but the lateral wall is thick. And in case this can be also filled by the uncemented stem. And this is dot type C, or this is stovepipe appearance of the canal. Here the medial, lateral, and posterior canal are thin due to severe loss of bone. These need the cemented stems. So see, this is a 55-year-old female patient, and she has osteoarthritis of the left hip, and there is thin cortex with osteoporosis. What will you use in this case? Likely cemented hip. And sometimes there are shorter patients, and most of the females in our country are also short, in case of 5 feet 3 inches less. And in these patients, the cup size required is 36 36 to 40 millimeter, but uncemented calves start from 44 millimeter. So in these cases, the cemented hips are needed, and a small medullary canal. So femoral stem also needed is cemented stem. So here also another case of 52 years with bilateral avian with secondary osteoarthritis. See, this is also cemented stem. So about uncemented stem, fixation is more biological. Material is titanium alloy or cobalt chrome alloy, and bone ingrowth into porous metal surface, which is shown in the figure, and it requires immediate mechanical stability at the time of surgery and immediate contact between porous surface and viable host bone. And uncemented stem, they may be proximally coated, as like here, and this may be extensively coated, but it is the individual patient's demand when you can use this proximally coated or extensively coated. So uncemented stem, this may be a porous coated porous surface, or this may be a hydroxyapatite coated. And you see a variety of surface modifications, including porous coatings, grid blasting, plasma spraying, and hydroxyapatite coating have been used to enhance the implant fixation. Many cementless femoral component designs feature combinations of these surface enhancements. Although the type and extent of coating necessary is controversial, most experts agree that it should be circumferential at its proximal boundary. And you see bone growth into a porous coating has demonstrated durable fixation for a multitude of cementless stem designs. And porous coatings have historically been created by either beads or fiber mesh applied to the stem by sintering or diffusion bonding processes. See here, it is the fully porous coated, and this is the proximally porous coated. So about hydroxyapatite coated, a study shown that mechanically stable, it is biologically also stable, and hydroxyapatite is osteoconductive. And hydroxyapatite enhances on-growth and in-growth. Hydroxyapatite does not accelerate wear and lysis, and underlying implant design remains the important thing. So there are some studies which favors that hydroxyapatite is superior to porous coated material, but some studies they showed that no difference in clinical or X-ray parameters in comparison to hydroxyapatite and porous coating implants. So there are 6 types of uncemented stem. Type 1 to 5 are straight stems, and type 6 is board stem. So in type 1 stems are so-called single wedge stem. They are flat in the anteroposterior plane and tapered in the mediolateral plane. And type 2 stems engage the proximal femoral cortex in both mediolateral and anteroposterior planes, so-called dual edge designs. They can be used safely in type A femurs. It's a more disparate group of implants. These stems are tapered in 2 planes, but fixation is achieved. Fixation is achieved more at the metaphyseal diaphragm. And 3C implants are rectangular and thus provides 4-point rotational support. And type 4 comprises extensively coated implants, and these are also needed for the revision cases and difficult cases with the narrow stem and narrow canal. And type 5 or modular stems have separate metaphyseal sleeves and diaphyseal segments that are independently sized and instrumented. These stems are many times needed. It is called the Strom implant, which is imported by Depot, and such implants often are recommended with alternatives such as developmental dysplasia. Very useful in femoral osteotomy and dysplasia. And see here, this is a 40 years old dysplastic hip. What will you do? The center of rotation of hip is higher in this case. You have to restore the center of rotation, and at the same time in this dysplastic hip there is more anteversion. So you have to correct all the things. That means you have to correct the 3 offsets. So how can it be? By using this Strom hip. Strom hip has the separate head, that is modular head, separate neck, modular neck, separate metaphyseal part stem, and also diaphyseal stem. And type 6. This stem incorporate a posterior bow in the metaphyseal portion and variably an anterior bow in the diaphyseal portion. So there are various implants, all work. Like this is the coral, you know very well. This is the Wagner stem, and previously I talked about the AML stem. So here, it is a 34-year-old female patient. What will you do? As the age is less, so I have done the bilateral uncemented hip for better fixation and longevity of the patient and longevity of the implant. And now see, here is the bilateral dysplastic hip. The center of rotation of head is even higher in both these hip. And what will you do? In this case also, you have to use the S-ROM. So there is also evolution of metaphyseal stems, make available as an off-the-shelf implant, optimize load transfer to proximal femur to maximize bone preservation. There are some benefits of metaphyseal stems, and see this in this case is a young active male patient. This narrow diaphyseal canal, they are narrow medullary canal, and in this case you may use this short metaphyseal stem. And another case where there was subtrochanteric fracture and angulation and united fracture, and in that case also you can use the short metaphyseal stem. So what are the components of this total hip replacement implant? Like it is the acetabular shell, this is the bearing, this is the head and neck and stem together. So what are the surface options? Bearing selection in THR. There is a mop, cock, mom, cock, and comb. So what are those? Here see MOP, mop, metal on poly. See here, this is the acetabular shell, but this is the polyethylene liner, and this is the metal femoral head. So metal on poly. And here see, this is the ceramic head, and which is on the poly liner. So it is ceramic on poly. See here, this is metal head, and also the liner is also metal. So it is metal on metal. And here, this is ceramic head, and it is on the ceramic liner. So it is ceramic on ceramic. So high level of metal ion systemic toxicity, 6 to 10% complication rates in Australian and other registries. So DP withdrawn it in 2010. And alumina ceramic wire debris highly biocompatible. Now a implant of choice is with ceramic head and ceramic bearing, that is the alumina ceramic, and best is 28 to 36 millimeter size. Okay, and the lower level of osteolytic cytokines compared to ultra high molecular weight polyethylene and less cytotoxic than the metallic debris, and better is 28 to 36 millimeter size. And sometimes the delta motion cup is needed for larger head size and also for a smaller cup size. And there is also some disadvantage of ceramic, like they produce a sound which is called squeaking, and sometimes a chip fracture of the ceramic. And these are the journals and meeting proceedings, so I could not reduce it. And they showed that metal on metal implants has the liability of prosthetic joint infection. So in the world now, metal on metal is not used, but other options are used. So here you see, sometimes we need constrained head. So in this case, we use the dual mobility cup. This is from Stryker and this is from Depot. What is the advantage? Where there is necessity of increased stability, where there is weak or poor soft tissues, and where is neuromuscular issues, and in complex primary situations where you have to maintain the anteversions, but due to the spinopelvic angle, sometimes anteversion cannot be maintained. So in those cases also dual mobility cup is needed. And also in the revision scenario, see there is a dislocation, and this could this need and dual mobility cup. So there is also disadvantage of this dual mobility cup. There may be intraprosthetic dislocation. And so about acetabular fixation, there is cemented and uncemented fixation. And see uncemented cup, there may be press fit alone, there may be press fit with augmentation, like the spikes here and the holes through which you can put the screw. And acetabular liner, what is your routine choice? Sometimes there is choice, sometimes we need to use this to prevent some dislocation. There may be flat, elevated rim or lateralized. Sometimes you use the flanged cup when it restricts the escape of cement and enhances cement penetration into bone during cup insertion. And see one problem. Here there is a protrusion acetabuly, and the center of rotation of hip is medially displaced. So you have to restore the center of rotation. How? You have to put the morcellized bone graft with impaction grafting, and then you can use the bone cement. And this is a cemented prosthesis with bone grafting. So you restore the center of hip. And head material, there may be cobalt chrome or ceramic, and the bearing surfaces, previously it was conventional polyethylene, but now it is ultra high molecular weight polyethylene. It is cross-linked polyethylene. There may be metal on metal bearing or ceramic on ceramic, but ceramic is preferred for mobility and also for longevity, and especially in the young active patients. So here see, hello, this is the conventional polyethylene. There is wear and tear, and this is cross-linked polyethylene. So effect of cross-linking on mechanical properties: increase yield strength, decrease ultimate strength, and decrease elongation to failure, and decrease impact strength. And this is the backside of conventional polyethylene. And yes, hello.
Hasan Masud sir.
Hello.
Hasan Masud sir. Yes. Hello. We are running short of time. A little bit.
Oh, okay, I'm just within 1 minute. Okay.
Okay. Okay, sir.
Yes.
Thank you.
This is the last slide. This is the last slide. So here you see this is also a dysplastic hip with center of rotation much higher. What will do? You have to maintain the center of rotation, which is here. So so you have to keep the head here. And how it is possible? Because there is a false acetabulum. So false acetabulum should be filled by bone grafting, and for bone grafting also you have to fix it by screws. So plan it properly so that you make the screw available beforehand for the total hip also. So this is the last but not the least. Thank you very much.
Thank you very much, Professor Hasan Masud sir, for your nice presentation. Now I am requesting all the panel of experts to unmute themselves, because I am trying to unmuting them. Could you, sir, please unmute? Chowdhury, Biru sir. I think he's not there. Thank you for the presentation, Dr. Hasan Masud sir. You have nicely elaborated the different types of stem and different types of cup component and bearing component of the total hip. There are a lot of questions regarding the total hip replacement. So first of all, from Lieutenant Colonel Abdul Kader, he's from, I think, from North Africa. Now he's there. His question is, which type of implant you advise to select for the young patient for THR and why? I think
yes,
Professor Hasan Masud sir.
Yes, thank you for the question. It is a pertinent question, and actually for younger patient, I would like to tell that uncemented hip is the best option, because the recent literature shown that there is long-term follow-up with this uncemented hip. Hello.
Yes, yes.
Am I able?
Yes.
Okay, so uncemented hip is suitable for them for longevity and also for the stability of the hip, and also there is bone mass is more there. So I would prefer the long-term result with this uncemented hip. But some papers from the Europe and UK, they are telling in the younger patient also they are using this cemented hip. But
Yes.
I am not in favor of that.
Masud bhai,
Yes.
can I tell?
Yes, yes, Dr. Biru, definitely.
Yes. Masud bhai, this is a opinion for our. I think there's for the Asian. I have an experience in Exeter.
Yes, 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 I know.
My, my teacher is here. The Rizvi sir is here, and in Exeter there is an tradition. Basically, they are doing the cemented hip.
Yes.
Whatever the age,
yes,
basically, there's the cemented hip is the. I think in my experience, the cemented hip is better than the non-cemented hip.
Thank you, Mr.
We have a limitation. Basically, we have a limitation because we don't have any the instrument. Cement impregnant on cement.
Yes.
Cement impregnant on cement. So not necessary to remove the all cement.
Yes,
that is the most important thing. So we have a limitation in our country.
Yes, yes, exactly. That is I have told that there is North Atlantic divide. One side they are a proponent of cemented, and another there is proponent of uncemented. Thank you.
What is the opinion of Rizvi sir?
This is Biru. This is the area still debate is going on. Okay, if you look at the literature and if you are trained in UK, you know that these people are using cement for over 60-70 years. Okay. And there are long-term results of cemented total hip replacement. Okay, these results, long-term results of cemented total hip replacement, initially cement earned bad name because the people started talking about this cement disease because the technique of cementing was bad. But when people started using new cementing technique, third generation or fourth generation cementing technique, the result is superior now. So if you look at the literature, you will find the short-term and long-term survivalship and complication in terms of revision surgery. Cemented total hip replacement is doing excellent. About 90% survived about 15 to 20 years. Okay?
Yes, sir.
Yes, sir. Yes, sir.
Regarding the non-cemented technique, if you go to America, over the last 1 decade, if you look at the American trend, you will see they do mostly non-cemented,
Yes,
and more than 90% of this hip replacements in America is now non-cemented. But this non-cemented technique is about 15-20 years now. So long-term result is coming up now. And there is some agreement about the cemented and non-cemented here. There was a economic analysis of the total hip replacement. They showed that if you use a cemented total hip replacement with a head size not bigger than 36 millimeter.
Yes, sir.
That proved to be very economic. Okay, for people older than 65 years.
Yes.
Okay. Non-cemented with a head size less than 36. Okay, then they found that that is quite economic. But if you use head size more than 36, or use a hybrid type of fixation, they could not prove any superiority. So debate is going on, but whatever the technique you do, actually, I tell you, I always tell this total hip replacement is an easy surgery, but doing it perfectly is a very difficult surgery. After this nodding his head, doing it perfectly is very, very difficult. And other findings I tell you, this location is more common after non-cemented total hip replacement. Do you know that?
Yes, sir.
I don't agree with you, sir. Rizvi sir. I don't agree that dislocation is more common in the
literature says. Hey, I mean,
is this, sir?
It is literature says.
Cemented dislocation more common, sir.
Dislocation
No,
is more
Amir bhai,
common
in literature, the dislocation is more in non-cemented.
non-cemented hip replacement. And in
Yes,
my
not
series,
cemented.
As because
case,
non-cemented head is larger than cemented, so non-cemented dislocation is less.
I prefer.
Hello.
একটু আনমিউট করে নেন স্যার, আনমিউট করে নেন।
আনমিউট করতে হবে স্যার, স্যার একটু আনমিউট করতে হবে। আমির স্যার আনমিউট, হ্যাঁ
আচ্ছা
হ্যাঁ হইছে স্যার।
Did you listen to me? Hey,
হ্যাঁ করছেন।
did you listen to me what I said
Yes.
before? It's okay.
No, sir. No, sir. No, sir.
Nothing. You didn't say.
No, just for the last 30 seconds.
Oh, okay.
Last 30 seconds.
What Amir was telling that dislocation rate is more in case of cemented total hip replacement. I said dislocation is more in case of uncemented total hip replacement. I'm quoting from the literature. Okay, I cannot put this reference right now, but I may be wrong. But even in my series, some of my cases, dislocation did happen following uncemented total hip replacement. Okay, but the one thing is that if that happens in my series, I didn't have to reopen none of the cases. I could manage this location without further surgery. But definitely, to me, this is true. This location is.
Sir, sir, I have an opinion, sir. Can I tell, sir?
Sure.
Sir, I have an opinion. Can I tell?
Sure.
Sir, Amir bhai little bit right for the Asian people. What is our tradition? The tradition is that we are doing the cemented hip in advanced age, sir. The advanced age, and we are doing the non-cemented in the younger age. So in advanced age, the musculature is weak. That is the cause of the large number of dislocation in our area. But in literature, the cemented hip dislocation is less than the non-cemented. I have an explanation in non-cemented as well, all over the world. The thing is that the non-cemented hip is the time requirement for impregnatation. There is a bone, the implant impregnate with the bone, the time needed for minimum 4 weeks. So some excited surgeon, what is doing? They are doing basically the after operation, remove the stitches and going to the work. That is I think that is not wise, basically. So my impression and my opinion is that what is the cemented, is there cement impregnant on cement, and cementing the hip is result is long term result is good. And if we do the younger age, that is not necessary to remove the all cement. Cement can impregnate on cement, so the result is very good than the non-cemented. But one disadvantage, extra half an hour is needed for surgery. That is the main disadvantage.
Another advantage, most advantage, important advantage of the cemented one is the cheaper.
Yes. Yes, sir.
So
Yes,
what do you
sir.
suggest?
So economy is very important issue in
what-
Bangladesh. It's okay. So sometimes we have to consider that as well. And
That is the main issue.
At the end, sir,
That is main issue, sir.
And
what do you
during my
suggest, sir?
surgery, what I do, I keep everything ready at the theater. Is okay?
Yes, sir.
If young people,
Sir, what do you suggest for us, sir?
it's okay. If
Yes, sir.
if young people, the trend now today is doing non-cemented total hip replacement. Okay.
But during surgery, you must available it the also cemented. As
Yeah,
that
I keep.
occasionally there is a narrow cavity and non-cemented steam cannot engage there. So cemented steam and cemented acetabulum must be available during surgery.
Yeah, for
Sir,
many reasons.
Sir,
For many reasons, you might change your mind
Yes,
during
yes, sir.
surgery.
Yes,
Okay,
sir.
it is
Yes,
the
sir.
surgeon's privilege to choose the appropriate implant during surgery. So,
sir,
my,
here
my
I can tell, sir, tell to two things, sir. One thing is the just 2 days back or so many time I have an experience about the stem of this femoral stem, sir. Sometime needed the femoral stem because we are Asians, sir. We have a narrow
Yes,
cavity, and
narrow
the
cavity. Yes.
problem is the neck, sir, neck of the stem. That is most likely sometime needed is CDH.
Yes.
So many times we need a CDH, and so many times. That is a accompaniment. They have in tradition. If we advise to give us the cemented, they will supply the cemented. But if we tell them non-cemented, they will give the non-cemented as well as the cemented. But I think I want to inform, Sarah, you just tell the accompaniment that both of the implants
Yes, yes.
could be available in the OT, whatever we will decide in the OT,
Yes,
sir.
yes.
okay, if you are a operating surgeon, it is your right to tell them. They must obey you. You don't abide by their rules. Okay, enforce your own rule. So during surgery, keep everything ready. Keep everything ready. Of course, in our country, you cannot get everything.
Yes.
If you are in a difficulty, if the cup is something uh, you have not expected, but if you want to use the same kind of implant, then you are in difficulty. So at least whatever implants available in our country, keep everything ready in the theater when you are operating. Is okay? Thank you.
Okay.
Sir, can we go for next presentation? Because there are questions. I think we can discuss this after completing that one. Can we go? May I request Dr. Jahangir Tuhin to share his screen for cementing technique. Dr. Jahangir Tuhin.
Thank you, Dr. Shantanu. I am sharing my screen now.
Okay. এবার যখন আমি আমার যখন ইস হবে তখন
Dear moderator, respected panelists, my teachers, orthopedic surgeons, and residents, good evening. I welcome you to today's second topic on cementing technique in THR. Let's have a look the learning objectives. We have to know a little bit about cement. What is this? What is bone cement? How it works? And tidbit when we doing a cementing. Antibiotic that's used in bone cement, and what are the ideal candidate in cementing for total hip arthroplasty. The adverse event that may happen during cementing and how to deal with it. After 1870, the German surgeon that invented the arthroplasty Themis glove, in 1930s, Otto Röhm described the polymerization of the methacrylate, but it is the father of modern arthroplasty, Sir John Charnley. He developed the science and arts of modern cementing technique. In 1969, Professor Buchholz added antibiotic in cement. In 1970, FDA approved cementing in arthroplasty. But nowadays, you all know there are cemented and uncemented, both are popular, and we all using this. Though there is a gradual increase of cementless prosthesis, cemented prosthesis is still the gold standard against which all form of implant fixation are assessed. Let's have a look the composition. We all know there is two component, powder component and liquid component. Powder component is polymer and copolymer. Liquid component is monomer. And there is a radical polymerization after mixing these two components. And some ingredient as a initiator and catalyst, and some only for radio opacifier. And how it works? It's not a glue, not a fevicol. It's like a filler, rather filling a gap. And it's create a mechanical interlock between bone and prosthesis. It also help in transferring load and restoration of the bone stock. One important concept is micro interlock. You know, in femoral canal and in the acetabulum, there is a trabecular bone which have some interdigitation of the bone or trabeculae, in which cement are penetrated, and about 300 kilopascal cement penetration pressure is needed for overcome the femoral canal blood pressure to displace, which try to displace cement from interdigitating within the trabeculae. So what we need: thorough, clean bone bed, brush, lavage, injecting cement until of its maintaining its viscosity so that it overcome the pressure within the femoral canal that try to displace cement bonding within the bone, and pressurization of the cement. We all know it is 4 phases. Mixing phase lasts for 1 to 2 minutes, and waiting phase also 2 to 3 minutes. And what is important is working phase. It's most important. How can we understand clinically working phase start? We put some bone cement within rinsed gloved hand. If when it is not hairy, it is not no more sticky, then working phases start, and you just introduce bone cement within the femoral canal or in the acetabulum. The last one is setting. It takes can vary according to manufacturer, but it is about 8 to 10 minutes. There are lots of talk about generation, but we all know it's completely day to day. It is more revised and polished. In initial Charlie's technique, it is hand mixing, and bone cement is introduced to femoral canal by finger, and there is a very little or no preparation of the femoral canal or acetabulum, and there is no use of restrictor or cement gun. But gradually this have come, the cement gun, distal restrictor, and retrograde can use to retrograde filling of the cement with cement gun. You see, after a pulsatile lavage, the bone is so clean and the trabeculae is clearly seen. And with this trabeculae, there is a micro interlock of the bone cement and bone. So in 3rd generation technique, there is a vacuum mixing which reduces the porosity, and integrity of the bone cement is much better, and which pressurization one more important. You have to maintain pressurization to overcome the femoral canal blood that try to displace bone cement in bonding with bone. So the use of centralizer is another one important thing of modern cementing. The proximal and distal centralizer, when we use it, is sometimes it called 4th generation cementing technique. At a glance, look for generation of cementing technique. What are the latest development? The latest development is cartridge mixing and delivery. In this device, it's very quickly universally mix the cement and mechanically inject the cement. So where just reduce the mix time, there is a more chance of decreased porosity, and have a rotatory handpiece which reduce the variability also, and the toxic fumes also not evaporate within the environmental operative environment. Few factors are more important: the ambient temperature, mixing process, the powder to liquid ratio, heat production, and viscosity. I just talk about ambient temperature and viscosity. You have to keep bone cement, if you want to keep it in refrigerator, half an hour before you can put it. But before cementing, you should remove it about 5 to 10 minutes before, and bring in your operating room temperature, which should be kept in around 21 degrees centigrade. And mixing process, if you try to vigorously mixing, then heat production is much more and polymerization will be rapid. So your working time will be short. So you should be gentle. And there should be a proportionate powder and liquid. If one is more, the problem you can face with the setting and working time. And another point is viscosity. There are lots of talk about low viscosity and high viscosity cement. High viscosity cement is much better, as because high viscosity cement dissipated the blood within the femoral canal or acetabular trabecular bone and help to interdigitate with the bone trabecule and creating a micro interlock. And it was also shown that high viscosity cement has much longer track record. What are the ideal candidates? You can use any patient. We already have a nice debate of cemented and uncemented replacement, but generally considered low demand, old osteoporotic patient and Dhar type 3C, and in revision surgery, you might need bone cemented arthroplasty. Let's have a look to femoral and acetabular cementing. First is bone bed preparation, canal opening and reaming, brushing, distal restrictor now placed, and pulsating levers was done. Now drying the femoral canal with hydrogen peroxide for gauze, and centralizer and pressurizer was keep ready. Now retrograde cement insertion with cement gun. You see nicely the femoral canal is filled with bone cement. Now pressurizer in situ, and pressurizer keep about 2 to 3 minutes. At last, femoral stem with distal centralizer is introduced. You should keep a thumb pressure on the medial side as to keeping the pressure when introducing your stem. So have a look to the acetabular cementing. Just ream, make a few holes within the periphery of the close mixing of the bone cement in a closed bowl. You see cement is ready now for introduction. Now cement is introduced in the acetabulum. We should keep the pressurizer ready, and with pressurizer access when using pressurizer, you should keep mind that in the under the transverse acetabular ligament some cement might be displaced, so you can put a bone graft here, or you have to remove the excess cement from this area. We all know the acetabular zone is described by Dealey and Charnley, and groin zone is well reputed for femoral cementing, both epi and lateral. How you grade this? Grade A, B, C, D is according to Barak's grading. You can assess postoperative radiograph. You see two examples. In first picture, there is a whiteout, is a good cementing, but in the second, you see some lucencing around the femoral stamen bone cement. So, in gradually B and C and D, more and more void and loosened line, so that this gradually decrease your cement integrity. There are another evaluation method proposed by Julius, alignment, air void and thickness of the cement mantle. Our goal is to at least 3 to 5 millimeter cement mantle.
Sorry, Jahangir Tuhin bhai, so time, I'm warning about your
okay,
time.
I have only few more slides. I will end within 2 minutes.
It is already 15 minutes. Okay.
Okay. So you can use antibiotic, which is high dose and low dose. Adverse event, most important is transient, fall of blood pressure. There are many causes: absorption of the methacrylate, dissipation of the blood, and lysis of the blood set. And one important is loosening of or displace of the prosthesis. And most serious complication is pulmonary embolism, cardiac arrest, cerebrovascular accident, myocardial infarction. These. Another important adverse event is bone cement implantation syndrome. It's not only depend on bone cement, it's along with the bone cementing procedure, it might happen. So sometimes we have to avoid using bone cement in active infection, hypersensitivity, if any of component. So take home message, modern cementing technique are the key to long-term success in arthroplasty, meticulous bone bed preparation and preservation of the bone stock, proximal and distal centralizer, pulsatile levies, brushing, drying, and retrograde cement application with cement gun and sustained cement pressurization. Thank you very much.
Thank you, Dr. Jahangir Tuhin bhai, for your nice presentation. I am asking all the panelists to unmute by themselves. So there are some questions about this second presentation, that is the cementing technique. About first of all, I like to ask Dr. Amir Hossain sir, that is, without cement gun, can we use the cement or pressurize the cement? Because sometimes cement gun is not available in our perspective context. Sir.
Nowadays, cement gun is available in everywhere. Without cement gun, it is not wise to do the total hip replacement, I think. As because in the Western country, third generation and fourth generation, they are trying. But we are now in the second generation. If you go to more back in the third generation, it is not wise to go for total hip arthroplasty, as because this longevity of the survival of the replacement is less in the without gun. If you do in the third generation, that means by plugging only, it will be less durable of the of the replacement, less durable, I think. So to the questionnaire, I think without cement gun, never do the replacement arthroplasty.
Okay, thank you, sir, for your answer. Next question is how the femoral canal geometry. Yes, sir.
May I
Sure, sir. Sure, sir.
talk on this issue actually? What Amir has said, that is very right. Okay. Without the cement gun, you should not do totally replacement. But the fact remains, in our country, we have been doing replacement surgeries. Okay. Apart from totally replacements, hemiarthroplasties is being done all over Bangladesh, in the rural areas as well. And the reality is, in many of the places, there is no cement gun available. The fact is, okay, if you do a non-cemented hemiarthroplasty, it's okay. But sometimes you have to do cemented hemiarthroplasty. And we have been doing, and still we are doing cemented hemiarthroplasty without cement gun. In those cases, there are techniques where you cannot actually match the third generation cementing with without the cement gun, but you can use, the technique is you will have to use a distal plug. Of course, you don't get the plastic distal plug. You can use a piece of bone to do the plugging. Okay, then you clean it up and then you dry it up as much as possible. Okay, then take multiple syringes. Okay, 5 ml syringes. Okay, when the bone cement is relatively in liquid form, okay, you use this, you fill up these syringes, okay, and put a rubber tube, saline tube inside of the canal, medullary canal, so that you can bring out the air. So when you're pushing the cement, so with this syringe, you can start putting cement inside from bottom. Actually, you cannot go right to the bottom, but as deep as you can, and then fill it up from bottom to up with the syringes. Okay, and then you pressurize the cement before taking out the tube to let the air out. Okay, pressurize with your fingers, pressurize with your some other instrument if possible, and then when the cement is setting, actually after 4 minutes or 5 minutes, when cement is viscous, okay, and almost will be set within 2-3 minutes, then you start putting the stem. Pushing stem is also can help you to pressurize the cement inside. So with this technique, okay, you can use hemiarthroplasties, cemented hemiarthroplasty without using the cement gun. But if you ask me, do you recommend that? No, I do not recommend that. But reality is that in many years to come, you may have to utilize this kind of technique before our hospitals are really well equipped. Thank you.
Thank you, sir, for the very nice clarification, because we have to borrow all the things before doing the even hemiarthroplasty. That is the cement gun should be available in all hospital for the nowadays. This is a very nice clarification. Next question is about how femoral canal geometry determines the use of bone cement. Is there Dr. Abu Zaffar Chowdhury, Biru sir? Biru sir is there. I think Rizvi sir.
Speaker,
sir.
actually,
Yes.
speaker has already some of the it was probably Masud was telling where
Yes,
you
yes.
have to use cement, where you have to use non-cemented. When the in fact this stop medullary canal is like a stop barrel. When it's white, almost at the proximal part and the distal part. Okay, where putting a non-cemented stem is difficult, will not get much contact at the proximally and distally. In that scenario, and that scenario, you can use bone cement. Okay, but when the bone stock is good, then when the door class according to the door classification, when it is A, B, okay, then it is okay. You can use uncemented stem. But when it is door C, okay, and the bone is very osteoporotic, in that situation, one should use cemented stem.
Yes. Thank you, sir.
Okay.
Yes, sir.
Okay.
Yeah.
Huh?
Yes, sir. Thank you, sir. Another question is, what is cement disease? May I ask the presenter, Dr. Jahangir Tuhin, what is cement disease?
Thank you very much. You know, there is a bonding between bone cement prosthesis and bone. So there are two interface. One is cement bone, another is cement and prosthesis. The cement and prosthesis is the most weak point. At that point, usually there is some debonding with time. Debonding causes some crack and debris of the bone cement, and there is a gradually aseptic loosening, and the body system introduces some inflammatory reaction. And there is also some wear and tear of the component that we use in arthroplasty. All this causes there is a particular disease which we call cement disease.
Good, thank you.
আমি একটু এড করি আমি একটু এড করতে যাচ্ছি you already mentioned in your presentation one syndrome BCIS bone cement implantation syndrome. That is also a bone cement disease. There are many manifestations, you know. So hypoxia, hypotension, allergic reaction, losing different thing. All these complications, early complications, and there are some late complications. All these things combine this syndrome. That is the BCIS, bone cement implantation
syndrome.
Thank you.
Okay.
Aseptic loosening or aseptic inflammation. Jahangir rightly said that this is the aseptic loosening or aseptic inflammation by the particulate of the bone cement, which causes loosening and inflammation also. Thank you. Thank you, Zaffar.
One একটা জিনিস আমি অ্যাড করতে চাই, even there are some report of intestinal obstruction following cementing in case of total hip or total joint replacement surgery. Abdominal complication পর্যন্ত হতে পারে, intestinal obstruction পর্যন্ত হতে পারে, এরকম রিপোর্ট আছে. So there are many complications.
Very rare.
So there is I think there are some question regarding the previous presentation. May I take the question? Some questions, sir. So one question from Professor Mufakarul Bari, sir. What is the ideal age for doing the total hip replacement in neglected DDH? Professor Dr. Amir Hossain, sir.
Yes, there is a nowadays no ideal time. It can be do in the after 15 years, as because no can say how how long he or she will live, and it can be do either total hip replacement in cemented or uncemented according to condition, and after 15 years, on 5 years. Can do the total hip replacement. So there is a no restriction, because we previously learned that after 30 it is better for total hip replacement, but nowadays we can do or many surgeons should do the total hip replacement in after 15 years also, on 5 years.
Sir, okay. May I ask regarding this question, a comment from Rizvi, sir?
Yeah, Amir is right. Actually, the hip replacement has expanded to almost any age now. Okay, if the patient is of DDH or juvenile arthritis, then you do see this in young age replacement surgery may be required. Okay, but but general understanding is that you will have to wait up to the maturity of the bone. Okay, if the patient is female, then after 14 years the bone matures, so you can do it in 15 years or onwards. I have the earliest age of doing the replacement total hip surgery is 19 years. Okay, so I don't have any experience of doing at the age of 15 or 16 or 17. I have experience of 19. But if it is DDH, so if you want to do the surgery, it should be done early. But 15, 16, 17 years is okay. People are doing outside. Thank you.
Okay, there is another
one thing adding to Sir Rizvi sir, as because quality of life is better after total hip replacement. So why we not do early? Why we wait 20 or 30 or 25?
No.
So we can give quality of life to the patient because there is a lot of modalities, and we can do a also after 30 years, 40 years or 25 years. So I think for the quality of life, we can do in more early.
Yes, right. You're very right.
Maturity.
Quality of life is very important nowadays.
Yes, sir. Yes, sir.
Can I add something?
Okay, sir. Yes.
yes, sir.
What is my opinion? It's not necessary always thinking what is the age of the patient. Basically, we had to think about what is the indication for surgery and what is the damage of the head or acetabulum. That is important basically. But one thing, the sir is always right. The action after maturation of the bone. After maturation, then we can do the 70. I had an experience in my series. I did it 15 years, and I did so many cases. I did in 18 years and 2022 and 20 because the Amir Bhai already told that the quality of life. I think the quality of life is demanding. Just now, recently, this is a very demanding approach.
Okay, thank you.
Okay, sir, there is another question with that from Bari sir. That is, what is the comment about pelvic surface osteotomy in case of neglected DDH?
Pelvic?
Yes, pelvic surface osteotomy.
Support, sir, not surface.
Sorry, sir, pelvic support. Sorry, sir.
Pelvic
Yes,
support
pelvic support
osteotomy.
osteotomy. Yes.
This is a very good surgery, especially if you consider the economic and social status of Bangladesh people. Okay, I know Professor Bari has experience of doing pelvic support osteotomies. When this patient is not a candidate for total hip replacement.
Yes.
Okay.
Yes.
If you can do the surgery, is not the indication of the surgery. Okay. Indication depends on many factors. Of these, economic factors, social factors are very, very important. So if you just do a surgery and then set this patient home and he cannot have this changed lifestyle, so that operation will fail very soon. For them, pelvic support osteotomy can be an option. But the problem is, this is the operation of the old days. Now people have started living or forgetting of these surgeries. And I'm sure nobody has seen of this generation, young generation at least, anybody has any pelvic support osteotomy in your hospital.
Sir,
occasionally CDA করা হয় স্যার
Professor Bari has experience of doing that.
DDH এগুলাতে করা হয়
sir, is the alternate is the alternate choice for totally replacement? I think it is not. If the patient is needed totally replacement, it's not an alternate choice of pelvic support osteotomy.
No, it is
because
not that. But definitely, all the patients are not candidates for totally replacement.
Yes, sir.
Okay? So for those patients, you can reserve these surgeries.
Yes, sir.
you can take a comment from Professor Bari as well.
It,
Hey, Professor Bari, where are you? Has he
I can
left?
talk.
Has he left?
No, there. Yes, Bari sir.
Some light
Unmute
of
karen,
this,
unmute karen.
pelvic support osteotomy.
Yes. Can you hear me?
Yes.
Yes, sir.
PSO, is there any problem? Is there any problem with the proximal femur? Neglected DDH at the
Yes.
age of 9, at the age of 10,
Yes.
13, 14, 15. This is absolutely indicated if you see the literature. And I have the publication in the MedCrave. You could click and go there. What is PSO? And PSO is indicated absolutely for neonatal sepsis and migration of the proximal femur upwards. And the canal of the femoral canal is so shallow that you cannot go through this total hip replacement. At the age of 8, what will do? Valgus osteotomy and varus osteotomy in the distal femur. And you can see in the literature, there are a lot of cases. Still nowadays, my friend Rizvi is telling that nobody is doing that. And still they are in the Western world also. If you see, Dror Pale is doing, Rosebrook from United States is also doing all these kinds of pelvic support osteotomy. Up to 24 years you can do. Nowadays you can go for total hip, it's okay. But how many times you have to change the total hip replacement? If you go for 15 years, you must have long-term follow-up. After 15 years, you should be changed. Again, 15 years you will change. Again, how many times you'll do that? If you wait for up to 30, this operation, total hip, this is for Western world, is okay. But for my country, poor country, from India, from Bangladesh, I love to do this. If any problem,
I do agree with you. Professor Bari, I do
Yes.
agree with you and appreciate you.
Professor
Thank you
Rizvi,
so
can
much.
I,
It is
can I
only
add
for the
something?
children, sir.
Yeah.
For the children.
Children below the age of 15 or 20.
Professor Rizvi, can I add
Yes,
something?
sure.
This proximal femoral osteotomy, support osteotomy is, perhaps you remember, the name is Sans osteotomy.
Yes.
No.
S-A-N-Z, Sans osteotomy. The big question is, once you have done a Sans osteotomy for any reason, like Professor Bari just mentioned, infective hip, loss of the head following infection, septic hip. Now you do a Sans osteotomy. Can you reverse back to a total hip anytime? I don't know.
Can I add in this, Kavi, Professor Kavi? This PSO, pelvic support osteotomy, was first done by Lawrence, second chance, and it was modified by Professor Elizarov. And you could go for, if you do this, you can do the total hip. I don't know they have got the experience or not. I don't have any idea, but literature says if you go for PSO at the earliest problem, you could go for total hip. In Western world, they are doing.
Kavi sir, I can add, nowadays, there is a no contraindication for the total hip replacement in any acetabular dysplasia or after osteotomy of pelvis. Nowadays, there is implant is available. There is a flange type, and there is a variety of acetabular implant. So we can do after pelvic osteotomy, we can do the total hip replacement nowadays.
Right.
But the problem is since you will be making a angular deformity at the proximal femur, that is the pelvic support osteotomy. Is okay. So doing total hip would be difficult, but you can do it. Definitely you can do it. You'll have to correct the deformities if you cannot get that kind of proximal stem of as Masud was showing, having a deformity at the proximal femur. There are implants, metaphyseal implants, which can be used for the total hip replacement. But definitely, I would say that after PSO, converting into total hip replacement would be a difficult surgery. Thank you.
Okay, sir, we're a little bit running short of time. So there are some cases I would like to present by Professor Amjad sir regarding his total hip replacement. May I request Professor Amjad sir?
Well, thank you, Mr. Imon, the moderator, and thank you, my friends, Professor Rizvi, this Professor Bari, Professor, our panelist, Professor Biru, and Amir Hossain, for the beautiful contributions in this field. What we have just heard from Kavi and other people is really, the two presenters beautifully presented. I just share a few cases which we are doing here in this country. I think the first case is with this related with this cementing and for implants. This is a case, you know, this bilateral, the bipolar hip done, cemented hip. What our panelist, our honorable panelist said that sometimes, and Professor Rizvi was telling my friend that we do this cementing, but you see the very difficult thing to remove the cement, particularly in our scenario, as Professor Biru was telling, because of our Asian size and also removing the cement, it may break and it breaks cement. So this is a case, you see, after removing this implant and putting a long, you need to put a long stem like this and cementing, and the cementing is a little bit a heavy one, the mantle is a little bit big, and I should follow it, we should follow this sort of cases later on. I mean, okay. So this is a case of, this is also a modular, this is a modular bipolar uncemented case, you see. This is a very, usable in our older age group when there is a lot of comorbidities, 80 years, 90 years, when you can't do cementing or you can't have time to do anything. What we used to do in our early ages, as Professor Rizvi was telling that there's bipolar, or unipolar we used to do in our early days, and it was hemiarthroplasty was doing first class. So this can be done also. And this is a case, you see, I would just tell this, our speaker, Professor Masud, can you tell how can you do, because you have got the protrusion, this is the protrusion of the protrusion here, and broken implants. How to remove this part of implant? You can remove this part with little difficulty. You are very careful because protrusion, you might break the femoral trochanter or any part. And but what to do with this part? Can you tell me, please?
Yes, sir. For the broken distal part, I think if we do an window and the lower part of the the stem, the distal stem, distal part, yes, sir. Yes. Then we can, and what is your tips and tricks, sir?
Yeah, this is beautiful. Yeah, making a window over here. You make a window over here, and then this is this case. You see, I think the cementing is good. No cement mantle is so much, and the long step, and where you have, this is here as this removal the stem and putting a long stem and then mesh with it. It's beautiful.
Sir, can you show me the previous slide? Can you show me the previous slide, sir?
Go back. Yeah. Why not? Yes.
Previous slide, sir.
Yeah.
Sir, I think it can be a distal part by the proximal way, as because there is a loose.
What I'm saying, sir? What I'm saying? What I see, the lateral cortex was broken, sir. The broken area of the implant, sir. Okay. I don't know. Most likely lateral cortex was broken, sir. In broken area. So why we do the distal window?
No, if you do not need to have distal window, because the broken area may be fractured, but how to remove it? If you,
the area is implant was the lateral cortex was broken, and the proximal part we can remove this, and the distal part we can remove this side.
I think it is. You see, this is an intact one. There's no blockage over here. You see, this is no blockage. Because I did the surgery, I know it. So that is a problem. So we have to remove it, yes. And this is the lady, She's working. She's 80 years old. Yeah, and then so I think this is a sharing to you because this is we can go and do this. Yeah. Okay. So this man, what our speaker was telling about the cementing. This is the fracture neck of the femur, and at the time of 65, she had this cementing. What Professor Rizvi was telling, and you were also, Biru, you were also telling the cementing technique. And this gentleman is now, you see, after almost 24 years. Yeah, okay.
Good cementing.
Yes.
Yeah.
No, sir. Acetabulam is too much thick, sir. Acetabulam is too much thick, sir.
Except the cup.
Anyway, next, yeah, okay.
Femoral cementing is good.
Yes, sir. Femoral is good, but acetabulam is too thick, sir.
It's too thick. The mental is little bit, yeah. Okay,
Yes,
okay.
sir.
I agree. This
Yes,
is a
sir.
man, and okay. This is the done in 1996. 24
Okay.
years old. Follow-up is
Yes.
20 January 20 in Sylhet. I think
Yes,
Imon
sir.
was there in Sylhet
Yes,
when we were talking about, and he met me that
Yes,
time.
sir.
You see,
Yes, sir.
Still the cementing is there. Yeah, Imon.
Yes,
Can you
sir.
remember?
Yes, sir. Yeah,
He
yeah.
came to our
Yes.
hotel when I was there, and
Yes.
then you see everything. Rizvi.
Hi,
Rizvi,
I'm
They
there.
take
So this is
lunches.
an example. Okay.
Hmm.
It is 96. How many years gone?
24 years.
24 years. Yes.
You're cementing.
Yes.
You're cementing without. I hope. I am sure it was not a third generation or fourth generation cementing. It was.
We were that time. So Rizvi, it was that time we were rubbish. We were
okay.
We just put, and then you see the stem was a Charlie stem. You see.
Yes, even then it survived 24 years.
Yes.
Yes, sir.
Yes.
Okay.
You cannot.
Sufficient time is gone, sir. Sufficient time is gone, sir. Yes, very good.
You should not blame the cement.
And he is now 89. And
Yes.
this hey, this man went to horse 3 times.
Yeah.
He was praying every time. Okay, next please. Okay,
Yes.
okay. So this gentleman, another gentleman, you see how much it is doing. He is 50 years old, and then he has also ankylosing spondylitis. See, here you see Dr. Professor Biru.
Yes.
I see this is the mental, and this man.
Yes.
Yeah, you were right. So mental.
Yes, sir.
You see, problem is here. This side, it was done in 1998. The follow-up, he's
Okay.
now in Newmarket. He's still in Newmarket. And
Yes.
actually, the cement mantle should not be more than 2.5. It
Yes,
is
sir.
around 2.5. So this man is working, and it is follow-up is 2019. So almost, you see, 20 years follow-up. And this side, he is still doing with this, but he is limping. Okay. So this is what I should show you. Yeah. This is another gentleman, yeah, lady, traumatic hip with fracture neck. So he's 60 years old. So then you see what Masud was telling. So I mean, ceramic on ceramic. Ceramic is ceramic. The shell is here multi. This is called pinnacle. You are using Biru, you are in a pinnacle.
Yes.
This is the hydroxyapatite corail type. Yeah. Okay. So this is another case, I think 46 years. Another case, you see ceramic on metal. That ceramic on ceramic, that one. This is ceramic on metal. This is ceramic, our head, and metal is our liner. Professor Masud?
Yes, sir.
You see that? Yeah. So, yeah. So this is the another case, you see. This is the young man of 35 years. Masud, can you recognize what is this?
Ankylosing spondylitis. Ankylosing spondylitis,
sir.
Ankylosing
spondylitis.
Oh, Amir, good. Thank you, Amir. Totally fused. You see how much he's a kyphotic back. So, okay, and see what happened. What you have shown just, Masud,
Yes,
that
sir.
he has got this dual bilateral TASR,
Yes,
dual mobility implant.
Yes, sir.
Four parts over the neck of the femur stem, you see. Four.
Yes, sir.
1, 2, 3, 4.
4.
Liner is here. This is the liner. And the head is there. So 4 parts. You see what you told. The same sitting bilaterally, very difficult case we had to do. So this is really, I think, praiseworthy in 2017. This is, I think, Rizvi can recognize our friend who passed away. He brought this lady to me in our hospital, and then we put this in she's 71 years, American lady. We put, you see, ultra high molecular weight polyethylene, UHMWP, ultra high molecular weight polyethylene. Yeah, and she's first class. So another lady, 55 years, and then she, you see this DDAs. Can you, Masud, can you identify what is the problem over here? Hybrid, this is a hybrid TA, sir.
Yes, sir. Hybrid is the uncovering of the acetabular cup more.
Yes.
Sir.
Lateralization.
Bhasan is not appropriate.
Yes,
Sir,
it is not appropriate, and lateralization of the
Medialization was less.
yes, medialization was less.
Medialization was less. That
Great.
Lateralization.
This
Yes.
is medialization. This is our case. Patient is started limping very much. In 2010, it was done. She doesn't want to do anything, but she's limping so much. I'm sorry for that. And yeah, okay. And he is professor, our renowned professor from Dhaka College, our teacher, Professor Abdul Abu Said sir.
Yes.
He has a, subcapital fracture of the neck of the femur. And then we had to go for, he was 78 years at that time. And Masud, can you recognize what is it? What is it? The head of the femur, the
Yes, sir.
oxinium head.
Oxinium, yes.
Oxidized zirconium.
Yes, sir.
Right?
Oxidized
And
yes.
then this cross-link polyethylene.
Yes, sir.
Cross-link, you have told it about the cross-link.
Cross-link poly, yes.
This is cross-link, very good, polyethylene. And then this is our acetabular shell.
The shell, yes.
Acetabular shell, this is the head, which is oxidized. So it was done in 2016, I think. And sir is still doing very good. And we had a party in somewhere. It's beautiful. So what you have shown, Masud, and really we are using in this country, that is, Professor Bari is here, everybody is here. Thank you so much, all these speakers, beautiful presentation, and the illustrious, our all panelists. Professor Rizvi is a great man. Professor Biru is doing a lot of cases, and Amir Hossain is also doing a lot of cases. Let's go ahead with this. Thank you so much for allowing me, moderator, to show some cases in our country. Right, thank you.
Thank you, sir. So we are at the end of the today's webinar session. I am requesting to give some concluding comment from Professor Abu Zaffar Chowdhury, Biru sir, and Rizvi sir. First, Abu Zaffar Chowdhury, Biru sir.
Today, then we were meeting my teacher, the Professor Abdul Rizvi, and Professor Bari, and Professor Kabi sir, and Amir bhai, Masud bhai, and moderator, Fazlur Kashim bhai, and audience. Very late, good evening. The topic is very good, and selection of the topic is very good. We learned too many things, basically, too many things, the technique of cementing, choice of the implant, and what is my opinion about this for the younger surgeon. Before going to operation, you just give the time for planning of the surgery. What we mistake time to time, the mistake is the choice of the implant and the type of the surgery after fracture neck of the femur. What I see in my student life, the Austin mode prosthesis, then after that bipolar prosthesis, cemented was the little bit used basically, but bones are too much osteoporotic. So when after doing the operation, the patient is always a common complaint. The implant is jumping, something like that. So we have to choice of implant and cement use or not. That is a very much important. And just finally, I want to tell these things basically. What is the age? The problem is the pelvic support osteotomy, the age of the patient, and total hip replacement. But my opinion is that always think about the indication of the surgery. If the acetabular cartilage is destroyed, so what is the remedy of the pelvic support osteotomy? There is no controversy. If the acetabular is intact, okay, we can give the support. for delay the surgery of the total hip replacement. That is the choice. But if the acetabular is destruction, so we have to do the total hip replacement surgery. But always think about after maturation of the bone, or whatever the age, the 17 or 18, and we can do the so many times the surgery. But I am always with the cemented arrow. But the result of the cemented total hip replacement, it is the related or depend on the technique of the cementing. What is the type of the cement is used? That is most important, because the technique is good and type of the cement is good. Already Professor Amjad sir showing that the 89 years old man, he is passing the 24 years after operation. So what is the good news? So always do this during surgery. We have to think about this. That is I want the permission from my sir. I am too hurry. I have been meeting in different room. I just stay there. I just come and talk with you. That if you give me the permission, I want to leave this program. So thank you, sir. So many things and good night.
Sir. Thank you, sir, for giving your precious time to us. It was a nice meeting with you. Just few words from Amir Hossain, sir.
Okay, thank you, respected my teacher, Professor Rizvi and Professor Amjad sir, and also who participate in this webinar. I think this is the good for learning of the juniors, and there is many things to learn in the total hip replacement approach, and others also expected. There is a lot of things we can learn, and I think in the future we can again on the total hip replacement approach and others complications and indications and others can be discussed in the future. In my opinion, this is the good discussion today, and both our presenters of the Professor Masud and Jahangir was well presented, and I think a lot of orthoplastic surgeons will be benefited from this webinar in the future. Thank you all.
Thank you, sir. As the topics is very much vast, so if you like to continue our session, I think we can continue for the whole night. But as we have time limitations, so we have to conclude. So lastly, Rizvi sir. So what is last comment for all the junior surgeons? So what is your comment regarding this joint replacement for the hip, regarding implant selection and cementing technique all over thing?
Okay,
Sir.
thank you very much, Shantanu, for beautiful moderation. And I would like to thank the organizers, especially the Farooq Qasim and the speaker, two speakers, very experienced, Hasan, Masud, and other speaker was Javed. Huh?
Yes,
Javed. And thank you, the participants, and a special thanks to Professor Amjad for showing us beautiful cases. So he is doing a lot of replacement surgeries, and he is doing a lot of teaching as well. Thank you for doing that.
Thank you.
Okay, regarding the comment, actually, so we all know this total hip replacement surgery is a very successful procedure. No doubt about that. It is a very successful procedure. That's why Charlie was knighted. Do you know that?
Yes.
Charlie was knighted by Queen of Elizabeth.
Sir John Charlie.
Sir John Charlie. So he was knighted for that development of this total hip replacement. And more than a million, more than 10 lakh, more than 10 lakhs procedures being done in America alone yearly. So in Bangladesh, we have population, if we consider half of America, then we will require at least 500,000 procedure per year.
Right.
But unfortunately, we cannot do that much. We are
Only
doing
only 1,000 per year.
doing only 1,000. But
Yes.
in fact, there are patients. Either patients cannot afford it or there are no facilities. Regarding this surgery, I always tell you, this is a very simple surgery, but doing it rightly and giving longevity is very, very difficult. In our country, we have two aspects to improve. One aspect is infrastructure. You cannot do this surgery everywhere. Okay? You have to have the facilities of doing this total hip replacement. And number two is improving the skill. You can improve your skill if you are very careful. If you want to really want to improve your skill by many ways, you can go. You can be trained here by some of your senior teachers. You can go outside. You can get training. That is not a problem. Okay. The thing is that the total hip replacement in Bangladesh, we have so many problems. One problem is economic problem. Other problem is getting appropriate implants. So far, the implants are available. You can do. The best combination is the debate of these cemented and non-cemented is unresolved. We have to resolve it in future, but so far we understand that if we can do a good cementing, okay, this cemented hip replacement can last for many years, 20, 30 years, and more than 90% can survive more than 15 to 20 years. If we can do the third generation cementing technique, forget about the fourth generation. There is no much difference between third and fourth generation. Okay, but in young age, since the tendency is for non-cemented, okay, for young people, you try to do uncemented total hip replacement. But in my practice, I do not compromise in the cup loosening. When I fix the cup, if it is a non-cemented, if you feel that it is not a press fit, then I change my mind. Okay, this is my practice. But I go for both cemented and uncemented. In general, for the old people, it is cemented, uncemented, it doesn't matter. But if it is a young group of people, try to do a uncemented total hip replacement. Regarding the material, okay, cross-linked poly is good. It has a less than 0.001 micrometer debris per 1 million cycle. And it is almost compatible to ceramic. So poly with metal head, poly with zircon head is okay. It does not cost much. Okay. So poly with metal, poly or zircon head is okay. Regarding the head size, try to use at least 28 millimeter. 28 millimeter to 36 millimeter. Don't go beyond 36. Okay. Unless it is a special situation. And other important point is do a proper pre-operative workout and do manage post-operatively nicely. And if you and regarding the theater, take special care about the theater. If it is in your own hospital, if you know the standard of the sterility, then it's okay. If you do not know that, then be sure that is being fumigated nicely. Instruments are doubly sterilized and the room is clean, well cleaned, and less people are inside the theater, and don't allow people to go in and out of the theater. These are the very important thing. And if possible, try to have laminar flow, clean air. If you can arrange these things, then you can do total hip replacement reasonably with a good result. Okay. And other important issue you know, nowadays people are using many approaches. Okay, it does not make much difference which approach you use. I still use posterolateral approach with the midi incision, not mini. Okay, some people nowadays shifted to anterior or anterolateral approach. Whatever the approach is, whatever in which approach you are confident, use that approach. It's okay. In Western world and in Singapore and other developed countries, they are using computer assisted surgeries. Okay, these surgeries actually that can improve some amount of orientation, and that becomes easier to put the thick cups and stem in right position, but it takes a longer time to do the surgery. Okay, in the last decade, or in the at least a few years back, people started doing total hip replacement using mini incision, okay, small incision. But the ultimate outcome could not prove it better, because the immediate benefit is there, because the recovery time was very short, but longevity of this surgery, longevity of this replacement surgery was not that great. So people has started leaving this mini incision type of surgeries, and this requires special type of OT table, special type of instrument, which is not available everywhere. And in fact, I personally do not prefer using mini incision, but I use a midi incision, not much, not big. Okay, that is a posterolateral approach. Jahid is working with me, so he knows. I'm quite happy with that approach. And you can discuss, there are so many things of this total hip replacement you can discuss, and every day things are changing. People are coming up with a new implant, new instruments, new material. Okay. So keep on tracking these things, especially the young surgeons. Go on reading, go on learning. Professor Amjad, I like him because he traveled to so many places to learn things. Okay, so this is a technique of learning things from other areas. So try to learn as much as possible, and learning yourself is not enough. So teach other people.
Exactly.
Especially the young teachers, you have responsibility. So teach young people, okay, and improve the surgical rituals. I'm very unhappy because in our government hospitals, okay, we could not improve much. We are not that keen about keeping the sterility. This is very unfortunate. We have better buildings, we have better hospitals, but in fact, inside we could not improve much. So young surgeons, please try to do something also to improve in that area with these few years. And thanking everybody. Kavi is there, and my friend, good friend Bari is there. Bari is always he is learning everything.
Exactly.
Other day I saw him listening to pediatric stuff. Okay.
Yes, sir.
And the other day he was in the spine session. Oh, okay. You are always there, huh? You don't have any work to do.
Dear,
Stop working.
why? Because it is everywhere.
Have you stopped working?
No, no, I am working in my house
fear of
now.
COVID. Don't do that. Don't do that. Give
Listen.
service to the people. So my request would be,
yes.
another request would be, okay, I know working in this at this age in this COVID arena is difficult.
Do you think that I am an old man? No.
No, yes, yes.
No, old.
Not ever.
No, thank you.
Doctor is always a student.
Yes, always student.
আরে আজকে তো আমি দাদা হলাম ডক্টর
Thank you. Congratulations.
Congratulations, sir.
Second time, probably, huh? Is that?
না না হ্যাঁ দাদা দাদা নাম আছে আগে
Okay, okay, you are very lucky. You are very lucky. Wish you good luck.
Thank you দোস্ত. Thank you so much
for your thank you, and thanking Kavi, then thanking Kashem, Fuzulok Kashem, Amir, then Wakil, and then other people are there, all junior people are there with these few viewers. And thank you again for giving me the chance to talk. Thank you very much.
Thank you, sir. Thank you for your very kind words to us. Your words will be always inspiring to us. And we are at the very end of the session. Just a thing, what Dr. Iqbal Kavi sir has shared, for the perfection of total hip replacement, one have to be obsessed, which is said by Professor Ian Learmore, very great arthroplasty. Thank you for sharing this statement, sir.
একটু কথা বলবো
Sure.
Unmute,
Sir, unmute, please, sir.
Unmute.
Yes.
Ian Learmore is a great hip arthroplasty surgeon of the last decade. His active tenure was between, I think, 70s, 90s. Professor Amjad, Professor Rizvi, they were at NITOR. They know about Professor Ian Learmore. You'll find his name everywhere.
Discussion.
In joint replacement, hip replacement arthroplasty. All references you'll find if you go back 10 years back. He was in NITOR. He came 2 times. লিভার এসেছিল, একবার পরীক্ষাও নিয়েছে, he took the examination, MS final examination, and we were very fortunate to have him here in NITOR. NITOR has a very, very big history, on a rich history, and very many great surgeons.
Professor Kavi, can I add just with a compliment? He is the pioneer for doing the lateral approach, anterolateral approach, that is a Hardin's approach by Learmont. He is the man who was pioneering doing this lateral approach from his early life, and still he is doing it. And he was propagating it that this is a good approach. Yeah, thank you.
তার একটা কথা আমার মনের মধ্যে দাগ কেটেছে সাংঘাতিকভাবে। One has to be obsessed.
Yes.
Obsessed বাংলা শব্দটা কি হবে? রিজভি স্যার?
পাগল হতে হবে, পাগল।
উন্মাদ। ঠিক আছে, পাগলই। উন্মাদ স্যার। উন্মাদ স্যার।
উন্মাদ হতে হবে to be a perfect surgeon. হয়তো এটা সব জায়গায় হয়তো প্রযোজ্য, is applicable everywhere, but in joint replacement maybe it is more applicable. Thank you.
Okay, thank you, sir, for your kind words. And I am requesting Dr. Fazlul Kashim sir to share, give the announcement of the next webinar. Dr. Fazlul Kashim.
Assalamu alaikum. We are very much grateful to our panelists, Professor Khondakar Abdul Awal Rizvi, Professor Abu Jabbar Chowdhury, Dr. S.M. Amir Hossain, our 2 speakers, Professor Mohammad Hasan Masud and Javed Iqbal Tuhin. We are grateful to Professor Amjad Hussain, and we are very much thankful to all the participants for their active participation, and especially to our senior professors Iqbal Kavi sir and the Mufakkirul Bari sir, and sharing their knowledge. We start our journey. It is our 2nd webinar. We will talk about the basics of the joint replacement. So we keep its name is the ABC of joint replacement, and we will continue the webinar in every Saturday at 8 p.m. The next Saturday is the 1st August. It is our Eid day, so there will be no webinar on the 1st August next Saturday, and the next Saturday after the next, on the 8th of the August, there will be a webinar at the 8 p.m. and the topic is the number 1 is the surgical approaches for total hip replacement, and another topic is basics of surgical techniques. We will share with you the details of the speakers and panel of experts in time, and I will request you all to be with us, and let us try to educate our young generation so that we can improve our skillness, our infrastructure, and we can prevent the complications related to the joint replacement. Thank you.
Thank you, sir. So this is all about today's webinar. This is the end. And I am, last of all, I am thanking all the panelists and the presenters for their brilliant presentation, and as well as all the participants for their patience hearing and to make the presentation webinar more fruitful and more their gracious present will make the made the webinar a very good one. And last of all, I am thanking all of you and say goodbye, good night, and stay safe, stay healthy, all of you in this pandemic situation. Okay, good night, sir. Thank you very much.
Thank you.
Thank you, sir.
Thank you, sir.
Everybody.
Thank you.
Imon, thank you.
Thank you, sir.